Good morning, good afternoon, good evening students. Welcome to the DSA for skin lesions. So this is a hefty topic. There is about 150 slides. I hope that this topic or this presentation will do justice to the topic. We will go through all kinds of different skin lesions. First we'll describe the lesions, we'll identify different lesions, then we'll go through the differential diagnosis, describe all the conditions that are associated with these lesions, and look at the clinical features, pathogenesis, diagnostic testing, and finally the management and treatment of these conditions. So let's get right into it. So the objective of this talk are to be able to identify skin lesions, to obtain focused skin history, to correctly diagnose common skin conditions, to recognize skin malignancies and life-threatening conditions, to become familiar with treatment and management of common skin conditions, and finally to develop a differential diagnosis based upon the appearance of the lesions. So on this slide is displayed the skin lesions mind map. So this mind map incorporates the use of epilogical approach, which basically is a 4-step approach and includes building probable diagnosis. In other words, you need to know based upon the appearance of the skin lesion, what are the differential diagnoses. The second step is to recognize any urgent or emergent situation, which basically will identify based upon the patient's appearance and different diagnoses that we are considering, and that is also displayed on the mind map in the red color font. As you can see, that is pemphigus and toxic epidermal necrolysis, and we'll go more in detail as we move along about these conditions. The third step of the epilogical approach is to weigh all the differential diagnoses based upon the appearance of the lesion and the differential diagnosis we are considering. And in order to weigh the differential diagnosis, we need to ask appropriate questions. So we'll look at that also as we move along. In order to, the fourth step of the epilogical approach is to remove anchor bias. In other words, not prematurely arrive at a diagnosis without looking at all the additional possible diagnoses for the lesion that we are looking at. So we'll follow the epilogical approach whenever we are approaching patients in a clinical scenario. In order to go through this DSA and look at all the skin lesions, we can see that the mind map has all kinds of different lesions on the left hand side, and these are basically starting from the macule. They are veal, papule, pustule, bullae, vesicles, and ulcer, and then there are some additional primary skin lesions which are not displayed on the mind map just because the scope of the mind map does not include those primary lesions, but we'll talk about those as we move along. Next to each individual skin lesion is differential diagnosis, and again you can see those are key differential diagnoses that are associated with these skin lesions, and we will look at all of them in more detail as we move along. Next to that would be the clinical features that are present, or the salient clinical features that are present in individual differential diagnoses, and those are in the green color font. And if you are not able to differentiate between colors, those are just displayed in front of the differential diagnosis in a color. So you can look at all those clinical features that are salient and associated with these differential diagnosis, and you can ask questions based on these clinical features to differentiate among all the differentials. And next to that is a few features that are in the brown color, and those are basically physical exam findings or additional physical exam findings. And finally, there are some features that are in the red color, and that is basically because we are identifying those conditions that are going to lead to the life-threatening situations, and so we need to be able to identify them quickly and make sure that we stabilize the patient and not causing any delay in the management. Lastly, there are some diagnostic features that are, or diagnostic tests that are included in the mind map. So the mind map is a nutshell of the entire presentation, but it does not include everything. So this is just like a framework for you to follow. So we'll insert this mind map in different slides as we move along. So as I said, that there are certain conditions that are mentioned in the PowerPoint or in the presentation but are not in the mind map, and these are necrotizing soft tissue skin infections, dermatitis herpetiformis, seborrheic keratosis, actinic keratosis. These are the diagnoses that are in the presentation, but they are not in the mind map. Then there are things that are not included in the talk or in the mind map, but those are skin conditions you may come across. Though some of them are a little bit common, but I did not include them because of the scope of the presentation. So one is scabies, which is a common pruritic condition, but because there is so much itching associated with it, and it's not necessarily a rash all the time, so I didn't include it. Then there are some skin conditions that are associated with common infections, for example, syphilis, HIV, Rocky Mountain spotted fever, and other things. I just used the general term infections and not specifically include these conditions because that would make the presentation very big, and those are possibly covered in other parts of the curriculum. So now I would like to make a case for skin. So skin is the largest organ in the body, so therefore it's big, and we have only one presentation for it. So the next thing is that every organ system can manifest itself in skin, and I would challenge you to come up with an organ system that does not manifest itself in the skin. The next is that inflammation is the key. So most of the skin conditions are going to occur as a result of inflammation due to underlying conditions. And then 7% of adult office visits are due to dermatology. 60% of dermatological diagnoses are made by non-dermatologists. So no matter what your specialty is, you are primary care doctor, internal medicine, family medicine, no matter what, chances are you are going to be making dermatologic diagnosis, so take it seriously. And in order to identify a lesion, what you do is you look at what is showing. So whatever does not fit or does not belong is a skin lesion. So there are two types of skin lesions, primary skin lesions and secondary skin lesions. Primary lesions are the ones that just appear or show up. Secondary lesions are the ones that occur as a result of manipulation of the primary lesions, like itching, excoriation, secondary ulceration, secondary infection, and things like that. So this slide has about a dozen primary skin lesions, so don't feel intimidated. It has a lot of information. We'll go through all of them in more detail as we move forward, but basically you can just memorize them in the form of pairs, or you can chunk them. So a macule is a flat lesion which is small, a patch is a flat lesion which is bigger, papule is raised but it is small, and then plaque is raised but it is bigger. So those are the two different pairs. Nodule is a round, small cystic lesion, and it is palpable. It can be solid or cystic, and it's not necessarily that big, but it can be between 1 to 2 centimeters. Then the purpura is raised. It's usually red or purple color, and it does not blanch. So that is the important piece of information. Pustule is something that's a little bit raised, and it has pus in it. Vesicle is also raised, similar to pustule, but it has clear fluid in it. And it's usually 1 centimeter or less, but in some sources it says it's 6 millimeter or less. So just look at either 1 centimeter or 6 millimeter, both answers would be correct. The bullae are the ones that are bigger than vesicles, more than 1 centimeter or more than 6 millimeter, based upon what reference you are using. Wheels are raised, they are intermittent, they are usually as a result of hypersensitivity reaction, and as we move along we'll look at them more in more detail. Hyperpigmentation is usually associated with a lesion, for example a macule. So a macule can be hyperpigmented, which means more pigment, or hypopigmented, less pigment. So that's all about all these primary lesions in a nutshell. This is brief summary. We'll look at more details and the differential diagnosis and the conditions associated with all of these primary lesions as we move along. Secondary lesions, as I said, are going to be the lesions that are going to be as a result of secondary inflammation, ulceration, manipulation, scratching, itching, and stuff like that. So there are only about 8 of them on this slide. So there can be excoriation, which is basically as a result of scratching, is going to be more linear. Lichenification is basically dry, leathery thickening of the skin, and that occurs as a result of chronic persistence of the primary lesion, and we see that in eczema, erythema chronicum migricans and stuff like that. Edema is basically just swelling of the skin, and that can happen as a result of water retention or fluid retention in the soft tissue. Scale is basically just superficial epidermal cells that just kind of come off and they just kind of cast off from the skin. Crust is basically dried exudate, and it can be from serum, blood, or things like that. It can be purulent, and it basically makes a scab. So that's basically crust, and we see that in some skin lesions that have persisted over time, usually after some infection. Fissure is basically a deep skin split that extends into the dermis. So there is going to be a little bit cut, and fissures are usually as a result of underlying medical condition. For example, we see fissures whenever people have ulcerative colitis. We see them in the anogenital area. We see fissures whenever there is an underlying infection or trauma to the skin and stuff like that. Erosion is going to be, or ulceration is going to be basically just a break in the integrity of the skin. So when it's very, very superficial, it's erosion. When there is more loss of epidermis, and it extends into the dermis, then we call it ulceration. Scar is basically going to be fibrous tissue that replaces the normal tissue as a part of normal healing process. So patients are going to come in and say that I've got this thing and it happened after this long time, and originally there was something else, and then of course you look at it, sure enough there is fibrous tissue as a part of the healing process, and that is a scar. So this slide is about taking history on skin lesions. So remember this mnemonic, old pen cat. You don't have to remember this mnemonic, but you can approach it anyway, as long as you gather all the information contained in this slide. So whenever you see a patient who's got a skin lesion, the first thing to do would be, of course, look at it if you can, and then you ask certain questions from the patient. So in old pen cat, O stands for onset. So you ask the patient, when did it appear, how did it appear, location, where is it anywhere else on the body, duration, how long it's been there, belief, what is the patient's belief about the lesion, episodic nature of the, so does it come and go, because that makes a difference. Certain skin conditions come and go all the time, and there are some that persist. If the patient has used any new item recently, so that may be related to the skin lesion. If the contacts of the household or members also have this similar problem, if there is any associated diagnosis, so for example, or symptoms, for example, patient has fever, malaise, or other things that suggest certain medical conditions, and treatment if the patient has used any medication or used any treatment for this particular lesion. So that is basically the mnemonic old pen cat. And then of course we can ask additional questions if the patient has any comorbid conditions, if they have any other diagnoses that they've had in the past or even recently, if they've used any herbal treatments, over-the-counter medicines, if they've had any stress in life, if, what is their hobbies, their occupation, their travel history, so basically social history, and then if they have any underlying allergies. So chances are, after you've gathered this much information, these additional questions plus questions related to old man cat, you would have sufficient information to make a working diagnosis, and then you move forward. So physical exam is going to involve basically looking at the lesion. So you do the visual inspection and you gather this information. You look at what, how many, and where. So you basically see what is the color of the lesion, what is the description of the lesion, the morphology. You basically need to be able to verbalize what type of lesion it is. Is it macule, papule, pustule, vesicle, bourrée, whatever it is. So you need to verbalize it by looking at the lesion. You need to know how many are present, so the number of lesions, what is the arrangement of lesions, that's extremely important. If they are grouped, they are scattered, they are clustered or whatever, or if, and also lastly, what is the distribution of the lesion if they are present in other parts of the body. So this slide is basically just showing what is the distribution of different skin conditions in different parts of the body, and this is just a reference slide. We don't have to necessarily memorize it. It's actually very hard to do that. This is another presentation of different skin conditions distributed all over the body. Again, this is just for reference, just to look at it, not necessarily need to memorize it. So next part of the physical exam is going to be palpation. So the palpation involves touching the skin lesion. So looking at the quality of the lesion. Is it dry? What is the texture? How does it feel? What is the skin temperature? What is the induration, which means thickness, consistency? If there is tenderness involved, does the patient have pain when you touch it? What is the depth of the lesion? And is the lesion fixed on the skin, or can it move? Then you also can press it to see if there is any edema, if there is any blanching, because if blanching is present, then you can differentiate between multiple different types of skin lesions. If there is any other defects in the dermis, which means basically if there is any breakdown in the skin. And then of course you need to also look for specific signs. Some of those things, for example, actinic keratosis, can be more felt than seen because it is so scaly. There are a few things, for example, Nikolsky sign, where when you touch the lesion or try to scratch it or move it, the epidermis will separate from the dermis. So that's a very specific sign seen in pemphigus vulgaris. So we need to make sure that we remember that, because that question will be asked again and again. Dermographism is a quality of certain skin lesions where when you scratch the skin surface, it will show a reaction. So we can see that, and that's found in specific skin conditions as we talk about them more in detail later on. Then there is auspice sign. There is additional skin findings that you can elicit based upon the palpation of the skin. So Wood's light exam is done with the help of Wood's light. So basically this is an ultraviolet light that is used to explore skin lesions, so you can see the skin lesions in more detail and can arrive at the diagnosis more easily. So it's another tool to do the physical exam. So dermoscopic exam or dermatoscopic exam is basically where you use a dermascope. So that basically magnifies the lesion and you are able to look at the lesion in more detail. Here you can see a nevus, which is basically a hyperpigmented lesion on the skin that under naked eye exam is not necessarily that obvious, but then when you look at under the dermoscope or dermatoscope, it is very clear what type of lesion it is. And then there is another lesion which is a small ulcer, and when you look at under the dermoscope, you can look at all the characteristic features of the ulcer. Now dermoscopes are widely available. You can buy them in primary care office. You can use them. Dermatologists use them, but they are not necessarily going to be the only thing that is required for the diagnosis. Oftentimes you can make a diagnosis without a dermatoscope exam. So Fitzpatrick's skin type basically is a representation of different skin types, where we move from skin type 1 through skin type 6 from the order of least pigmentation to highest pigmentation. So skin type 1 has the lowest amount of pigmentation. As you go anti-clockwise on this slide, there is skin type 1 and then there is skin type 6 that has the highest amount of pigmentation. So skin type 1 is going to also burn all the time and will not necessarily tan. Skin type 6 on the other hand is going to not burn and is always going to tan very easily. So there is tannability, there is burnability, and there is pigmentation. And those are basically going to be the characteristics of all these different skin types. It's important to know what skin type you are looking at, because that changes the way your diagnosis is going to be made, because different diagnoses are going to display differently on these different skin types. And we'll talk more about it, skin color later. So these are the top 10 skin conditions that we take care of in primary care practice as well as in dermatology practice. And these are just displayed on the slide. So it's a good idea to become familiar with all of these. So this slide is about color of skin and skin of color. Whenever we are looking at patients with different skin types or skin colors, it's important to know what type we are looking at, because there is going to be differences in the way different skin conditions present. And although there is not going to be that much difference, but even if there is a little bit of difference, we don't want that to be the reason for us to make the wrong diagnosis. So a few things to remember or keep in mind would be that the redness is going to be difficult to see, because in darker skin color. So whenever there is more pigmentation, red color is not going to be as obvious. So for example, in patients with rosacea, telangiectasias are not going to be all that prominent. In rosacea, normally there is redness in the central part of the skin or central part of the face. It's not going to be all that visible in darker skin color. Red scaly skin is going to be very difficult to see, because it's going to look more grayish and more violaceous. So for example, patients with eczema or psoriasis, they have red scaly skin. In darker skin color, that's going to look grayish and violaceous. So keep that in mind. Active inflammation may appear as post-inflammation. So you may not feel that it is actually active inflammation. You may think that, oh, this is just post-inflammation because it is hyperpigmentation. Hyperpigmentation in darker skin color will set in very fast. So you may misdiagnose it and you may think that it is post-inflammation or post-inflammatory hyperpigmentation, whereas it may actually be active inflammation going on. Papules, for example, in darker skin color are going to appear darker. So that is another thing to keep in mind. So for example, patients with acne, they may not look, or eczema, they may show papules in Fitzpatrick 4, 5, or 6 type. And it may appear to you as if these are darker spots, but these actually may be just active papules. Purpura may not even show. So purpura is basically raised papular lesions, which are basically, raised lesions which are going to be red or slightly red or purple color in lighter skin color, but in darker color, it may not even show very well. So that is something to keep in mind. And then lastly, everything dark will become darker. So post-inflammatory hyperpigmentation is going to be darker, eczema is going to be darker, melasma is going to be darker, solar lentigo is going to be darker. So anything that basically causes pigmentation in Fitzpatrick 4, 5, or 6 is going to be even darker, because the body just has a tendency to make more melanin. So there will be more dark color. So these are some of the things that we can keep in mind, and as we move along, we'll look at different cases, we'll look at different skin types, and we'll see how to correctly identify these things and come at the diagnosis correctly. So as an example, this is a patient, these are two different patients of two different skin types with COVID toes. So one patient has got lighter skin color and there is COVID toes, and those are basically red and inflamed, and they look clearly erythematous. On the other hand, patient with dark skin color also has COVID toes. It looks a little bit red, swollen, but the redness is not necessarily there. Inflammation doesn't look that obvious, so we need to be able to identify it and make sure that we don't misdiagnose it. So this is an example of drug-induced hypersensitivity in a patient. On the left side, there is a lighter skin color, a patient who's got erythema. It's all over the body, it's confluent, it's inflamed, it's raised, it's mildly swollen. So there is drug-induced inflammation. On the right side, there is darker skin color where there is some skin discoloration, but the redness is not obvious. Edema is not all that obvious. There is grayish hue. So this is an example of drug-induced hypersensitivity in a patient. On the left side, there is a lighter skin color, a patient who's got erythema. It's all over the body, it's confluent, it's inflamed, it's raised, it's mildly swollen. So there is drug-induced inflammation. On the right side, there is darker skin color where there is some skin discoloration, but the redness is not obvious. Edema is not all that obvious. There's grayish hue. So when you look at it, then you need to be able to identify it and say, okay, well, because of the skin type, the features of this condition are not necessarily consistent with the classic textbook picture. So this is cellulitis in a patient. On the left side, there is a patient with lighter skin color who's got redness, who's got edema, who's got swelling. So there is clearly cellulitis or inflammation of the skin. On the right side, there is dark skin color. So there is a little bit of swelling, there is a little bit of demarcation, there is a little bit of pigment change or a difference in color between the normal skin and the inflamed skin, but it's really not that obvious. It's very subtle, so it's important to keep that in mind. So in this particular slide, the patient with Lyme disease in a light skin color has got a clear bullseye type rash. It's an expanding circular rash, so it's erythema that's expanding. And on the other hand, the patient with darker skin color also has erythematous rash that's expanding, but as you can see, it's violaceous, it's grayish, it's not all that obvious, and demarcation is not necessarily clearly there, so we need to be very cognizant of that. So this particular patient or these patients on this slide, there is darker skin color and the patient has eczema on the extensor surfaces. So on the very left side, you can see that there is an image that has knees showing, so the extensor surfaces have eczematous lesions, and then there is another picture that has eczema lesions which are not really that obvious, but on the right side there is a patient with lighter skin color. On the flexor surface on the elbow there is eczematous rash, so it's more obvious. So the geographical distribution of the rash may also be different in darker skin color. So eczema may be on the flexor surfaces extensor surfaces as opposed to typical flexural surfaces. Another example showing that the geographical distribution of the lesions may not follow the typical textbook picture in darker skin color. So melanoma here in the darker skin is in the soles, and it can also be in the palms of the hands, whereas in lighter skin color that's not going to necessarily be the case.